Chapter 5, Children with Autism Spectrum Disorders. ASD, or Autism Spectrum Disorders, was first described in 1943. In 1996, three characteristics were identified as always present in children with ASD. These have become key definers of ASD: failure to develop social relationships, language deficits with impaired comprehension, ritualistic or compulsive behaviors. Since 1992, the knowledge about ASD and ability to develop effective interventions have rapidly expanded. As a result, there has been a 500% increase in the number of children diagnosed as having ASD since 1992. So remember that even though the media represents it as an epidemic, because we are better at diagnosing and defining ASD, it's not an epidemic. We're just able to identify it more effectively. As our understanding of and ability to identify ASD improves, the rates of children diagnosed as having ASD continues to rise. Some estimates suggest that as many as 1 in 50 children may be impacted. For every 4 to 5 boys diagnosed, only 1 girl is diagnosed. This supports a genetic component of the disorder. So early identification is crucially important for children with ASD. So we want to make sure that we utilize screening tools, take a look at whether they are able to pretend, their imitation of adult behavior, pointing to objects on request. These are different types of screening tools that have been developed. Early identification is crucial, as intervention in early childhood can mean big gains in language development and communication skills. So what are autism spectrum disorders? You can see here a Venn diagram depiction of these, and autism is in the center. The outlier on the right top is Asperger's syndrome, which tends to be an aspect of autism spectrum disorder that results in higher functioning. Child disintegrative disorder, which is one of the more severe, and then Rett syndrome, which is directly aligned with the administration of aspirin in early childhood. So causes of autism. Early on, in the beginning of ASD, there were theories about mothers and how they treated their children, and the theory was that they were cold refrigerator mothers, and that hasn't panned out as proof, and vaccines as a cause for ASD has been disproven, and in fact the origin of the theory about vaccines was actually fabricated. It was fabricated research. That medical doctor that created that fabricated research his medical license has been taken away, and that was not at all valid. Doesn't mean that there may not be some children that have reactions to vaccines, but it's not been directly related as a cause for autism. The tendency of ASD to run in families, so studies with identical twins have strengthened this hypothesis. It's likely that genetics act in combination with environmental factors. And MRI technology has revealed that the white matter connecting parts of the brain and mirror neurons are two areas of promising work. So these are two areas that may give us hope for changes in the future. So identifying children with ASD, and this comes from the Diagnostic and Statistical Manual, Edition 5. An individual must meet all four criteria, not 5, but 4. Persistent deficits in social communication and social interactions across contexts. Restricted, repetitive patterns of behavior, interests, or activities. Symptoms must be present in early childhood, but may not become fully manifest until social demands exceed their limited capacity. And symptoms together limit and impair everyday functioning. So as we look at our information processing model, then you can see that primary effects are executive function, under thinking and processing, reasoning and evaluation skills, and then under response, social interactions. And then associated with that is attention with informational input like vision and hearing. Under thinking and processing, memory, classification, and associations. And then under response or information output, speaking, writing, motor response also is associated with autism. So some characteristics of children with ASD. They have communication difficulties, which can lead to aggressive behavior out of frustration. Children with ASD often lack theory of mind. So typically developing children have a developing theory of mind by age 4. It's not completely developed, but they're beginning to understand it. So when we talk about theory of mind, what does that mean? It's the ability of humans to understand the thinking and feelings of others that is necessary for understanding, predicting, and shaping the behavior of others. Children with ASD may also be hypersensitive to sensory stimulus or input from all 5 senses. It might be sight, bright lights. It might be sounds, the pitch of sounds. It might be haptic, so touch. It might be taste. And so all of it, hypersensitivity to one or more of those. Central processing or their thinking skills. It may affect their decision-making skills, their problem-solving skills, and in executive functioning, their reasoning and evaluation skills. And it also can affect their response mode or output. So their motor skills, both gross and fine or large and small. Motor planning or moving their body in space in a coordinated and effective manner. So when we're providing services within the classroom, then the RTI approaches for students with ASD include Tier 1. 39% of students with ASD spend 80% or more of their day in the general ed classroom. Tier 2, students with ASD need more intensive small group instruction, focusing on particular behaviors or skills. And then at Tier 3, students with the most intense needs require 20+ hours a week of special programming to make and maintain gains. So there are special centers for ASD research and training. UCLA has a Young Autism Project utilizing the LOVAS method of ABA, and that has to do with antecedent behavior and analysis we've talked about previously. and then prompting and differential reinforcement to help deal with the issues related to ASD. Teach, that's acronym TEACCH, out of the University of North Carolina at Chapel Hill. And this program focuses on training parents, utilizing pictures and visual symbols, and then domestic and independent living skills. LEAP, with the acronym LEAP, from the University of Colorado at Denver. This focuses on independent play and social skills, and this is one of the areas, play is one of the areas where children with ASD would be very limited in their abilities to play, and this is an area where we can facilitate and support them in developing this skill. And then discrete play skills such as play imitation. And then the pivotal response model from the University of California at Santa Barbara, focusing on natural settings. So change in pivotal areas that can be generalized. In other words, address certain situations and then work towards making them generalize to other situations. Self-management, motivation, and self-initiation. And we keep hearing those approaches over the last 3 or 4 chapters. Curriculum and instruction for students with ASD focus on communication and perspective taking, both heavily emphasized in the English aspect of Common Core curriculum. Preschool programs for these children may focus on explicit instruction, which means skills typically developing children learn through observation, but that children with ASD may not, so they need some direct instruction regarding those skills. And then for school-age students with ASD, they will have an IEP developed by a multidisciplinary team with tiered assignments and focusing on the use of functional behavioral analysis, which we've talked about before. So instructional strategies for students with ASD. Strategies that create order and structure are especially helpful for students with ASD because of their compulsive and obsessive tendencies. Visual schedules can help children with ASD cope with disorganized environments. Diagrams, visualization, pictograms, photos, role-playing, and social stories can also be used to directly teach and reinforce social skills. So some types of assistive technology that can be used. If we use assistive technology, this can helps children with ASD to engage with the curriculum and with the social world. They can use augmentative or alternative communication devices with all kinds of technologies, PECS and VOCA, which allow children with ASD to communicate more effectively. And robotic dolls and special computer software have been successfully used to teach social skills and to enhance children with ASD's ability to read emotions and to respond to them effectively. Something to keep in mind as we're teaching those direct and skills and explicit instruction in regards to responding to emotion, keep in mind that we can teach the behavior, but it's difficult to pass on the understanding of why that behavior must be carried out in a social environment. Intervention effectiveness. Research has shown multiple types of interventions to produce positive gains. Treatment should be tailored to individual needs. And some intervention types include focused intervention practice, comprehensive treatment models, which just means they cover lots of areas of need, early intervention behavioral interventions, or early intensive behavioral interventions, EIBI, and intensive work on social skills. So family and community. The stress that often comes with having a child with ASD can be mitigated by teaching families effective intervention strategies. The relationship-focused interventions, or IRF, use responsive interaction strategies during routine interactions. So kind of taking the approach we do with infants as we do daily routines, which, by the way, is very important to a child with ASD. Having those consistent routines, we can provide relationship-focused interventions during those times. There's limited information about how students with ASD transition to work and community. All IEPs for older students should include transition plans.